reminders around the interpretation right now. So if you can see my screen right here, if you're joining from a computer, I invite you to click the globe that's at the bottom of your screen that you can see in this orange circle. Select the language in which you would like to listen in and participate in today. And if you're joining from a cell phone or a tablet, it's a similar process. Just look for three little dots that are on the corner of your device. Click those three little dots, click where it says language interpretation, and select the language in which you would like to listen in and participate in today. And I will repeat these instructions in Spanish now. Así que buenas, mi nombre es José, también estoy empezando a usar el nombre Omni y estoy usando los pronombres ella y les. Voy a ser su intérprete de inglés y español simultánea hoy. Nomás estaba mandando un poco de amor a Wanda y a Kerry Thomas que están en la llamada y voy a continuar con las instrucciones de hoy para poder acceder a la interpretación como hemos estado haciendo durante las últimas cuantas conversaciones. Si se están uniendo a través de una computadora, lo que van a hacer es seleccionar el globo terráqueo que está al fondo de la pantalla, seleccionar el lenguaje que les gusta escuchar y participar en. Si se están uniendo a través de un celular o una tableta, es un proceso similar. Nomás busca esos tres puntitos que están en la esquina de su aparato, selecciona esos tres puntitos, selecciona interpretación de idiomas y luego seleccione su idioma en cual le gustaría escuchar y participar hoy. And just a reminder to please speak slowly, speak one person at a time, take a breath. Y nomás un recordatorio de hablar lentamente, hablar una persona a la vez y recuérdense de respirar. And with that, I'll pass the mic back.
Before we move ahead, Barb, since you're here, I'm going to stop this live stream because it's on my page and not the caucus and let you do it, okay?
Okay, good. I just wanted to Yeah, Martha, we have some technology challenges, so if you can just give us a minute, that would be great.
Sure.
Okay. Ebony, you need to make me the host. All right, and hang on just a second. I'll let you know when we're ready.
Chattanooga, Tennessee. Yeah, and while we're waiting, we can actually go ahead and do that. As you can see, some people introducing themselves in the chat. So please feel free to put your name, pronouns, and where it is you're showing up from. Thank you all for showing up on a Monday night for the community conversations.
All right, Tammy, can you verify that we're on Facebook now? We should be.
Yes, you are now.
All right, wonderful. Thanks for letting us know. Martha, back to you.
All right. Well, I am happy to pass the hot potato back to Ebony to see if she can lay some foundation for us about our partners and our hosts for this community conversation. So, Ebony, you want to speak about the caucus and the POP grant that enables our community conversations?
Sure, but Barb is here and she is the expert at it and she's here to do it. I mean, let's give it to Barb.
All right.
All righty. I would love to talk about the People Organizing Positively project. So welcome, everybody. We're going to have an amazing conversation. This is intended to be a community conversation led by and for people living with HIV. We know and honor our subject matter expertise on what is best contributing to our sense of well-being, not just biomedically, not just about medications, not just about access to healthcare, but what helps support us in our communities as people who live and sometimes are able to thrive with HIV, and sometimes the struggle is absolutely real. So this community conversation is provided as a part of the People Organizing Positively grant. It's funded by AIDS United, and it is a remarkable opportunity for organizations, especially small organizations, to apply to be a part of this cohort. There's 10 groups that are in it. The CIRA Project is one of our grantees this year, and so we're so glad to see everyone involved with the CIRA Project on this call. It is an intentional opportunity to reach into our communities and to support organizations that elevate the meaningful involvement and the intentional involvement of people who are living with HIV. We know that some of our organizations that serve our communities do not always know how to do meaningful involvement well. And so these are specific groups that have applied, saying that they want to be part of elevating leadership, both organizationally, but within our community on a broader scale. And so we are really grateful to be here, to elevate that leadership, to develop leaders living with HIV, and to know that when we are able to understand our power and the importance of our voices, that we all succeed in so many different ways. We are just about entering the last month of this particular grant cycle. Hopefully there will be another grant opportunity to develop leaders living with HIV soon. We'll make sure and share it with everybody, because as we're supporting people, we have not only just the organizations that are funded, but we also have ongoing community conversations that are led by us and for us around issues that most impact our lives. And we also have coaches who are hired from within our community who share their expertise, and an evaluation team that also supports. And everyone who is involved in this project is a person who is living with HIV. So we don't have to spend time explaining why things that impact us are so critical, because everyone so deeply from lived experience about why that is critical. And that is the People Organizing Positively Project. And we are so grateful to be in our 7th cycle and to be coming here supported by AIDS United. So thank you. And I will pass it back to you, Martha.
Thank you, Barb. I'm so excited about today's conversation. We have been talking about quality of life over the past 2 years, and well, spotlighting quality of life. We know that as people who are living longer and aging with HIV, our lives have, not just been about our biomedical care. So one of the, I think, amazing things that happened about 2 years ago was when networks of networks got together, a network of networks through the caucus got together to basically author a document, a brief that was called Demanding Better. And some of you may have heard about it. I will just say briefly that it was unprecedented. It was the first time people living with HIV and organizations got together to essentially create a clear roadmap for the administration and Congress to achieve these goals of ending the epidemic. And we know that even if the epidemic is ended, it would not end without the people who are still living with HIV, right, until they find a cure. And so this was a clear roadmap of improving the quality of life for people living with HIV. And it had 5 issue areas. And those issue areas were MIPA. Barb so effectively talked about MIPA. That's why we're all here. We're all about the meaningful involvement of people living with HIV in our organizations, and in our daily lives and in our advocacy. We also demanded to create a human rights environment for people living with HIV in the United States. The United States is the only place in this universe that has not approached HIV from a human rights perspective. And that's why we tend to see some of these disparities. They're basic things that are human rights, including healthcare, that are not counted here, are not considered that. Otherwise, not only would they be free, but they would be equitable among all. So we also demanded an end to racial and gender disparities. We all know that racism and systematic oppression drives this epidemic. And we demanded that sex workers and immigrants be treated as priority populations. Everywhere else in the universe of HIV, they are priority populations, and everybody knows that we cannot end this epidemic without these two populations being treated as priority. And then the one and big final thing that we talked about was quality of life for people living with HIV and what it meant. This was done with consultation from all kinds of different groups, and everybody contributed to this discussion. And what was amazing was the very next year, the National HIV/AIDS Strategy for 2022 and 2025 that was released by the Office of National AIDS Policy ended up including, initially they said it was going to be a quality of life indicator one when it was released for World AIDS Day in 2021. But by the time they released the implementation plan the following year, last year, we discovered that they had made it a 5-part, multi-dimensional 5-part quality indicator. And that was because they had heard what we had to say about what it meant for people living with HIV. And this is just what I call the first floor. This was just the entrance of quality of life for people living with HIV, but they did include 5-part indicator that included the well-being of people living with our physical well-being. It included nutrition, it included unstable housing, it included employment, and finally included mental health. And this was a huge success for our community, but it's only just the beginning. It's only just the beginning. And today we have an amazing panel that is going to spotlight what some of these issues are and what they mean for us day to day as people living with HIV. What does that really mean for my quality of life when I wake up in the morning? What does it mean that the National HIV/AIDS Strategy is even considering this? They may not be doing anything about it, but we need to understand what it means or what it should mean, what is missing that would help us advocate and speak about the quality of life whenever we are speaking in advocacy spaces. So really excited today because I have 3 amazing speakers that are going to speak about this. And I don't want to waste too much time. We're going to get right into it. And then obviously we'll also have time for question and answer. If you don't want to forget your question, make sure you put it in the chat, but we will absolutely have time for question and answer at the end of this. And so without wasting too much time, I'm going to go ahead and introduce Sylvester Askins Jr. And maybe you can tell us a little bit about you. I will try not to sneak out that I'm so proud to be working with you, but go ahead and tell us what you do and then share a little bit about one of the indicators, which is employment and unstable housing, and what it means for us as people living with HIV.
Thank you, Martha, and thank you everyone for this opportunity to be here tonight. I am also truly excited about working with you, Martha. Again, my name is Sylvester Askins Jr., and I am the training director at the National Working Positive Coalition. The National Working Positive Coalition is committed to strengthening responses to employment needs of people living with HIV or at greater vulnerability. Just a little bit of context and background about me. Employment is not new to me. Before going to be a part of National Working Positive Coalition, I used to be a labor organizer. I worked for 2 major labor unions where I had the opportunity to help union members strengthen their membership and strengthen their new contracts. I also ran a Ticket to Work program in Norfolk, Virginia, where I assisted individuals who are on disability who are contemplating going back to work. I'm also a trained benefits counselor, so I have the ability to tell people how going back to work will affect their benefits. And also, I work as a consultant at the University of Virginia Department of Medicine ID Clinic, where I assist their patients who are contemplating going back to work. I give them information, resources, and tools to make a well-informed decision about going back to work. Employment is one of those things that I feel is a parachute to, not a parachute, is a springboard to a better quality of life. You know, they did not believe that we were going to live, so they didn't plan for us to age. They did not, because they didn't plan for us to age and plan for us to live, they did not ever think that we would be in a position to go back to work. A recent CDC report stated that 39% of people living with HIV in America are unemployed or underemployed. And that's a very staggering and upsetting statistic. During the period from June 2021 to May of 2022, again, 39% of people living with HIV were unemployed or underemployed, while during that same period, the rate of unemployment for the general population was from 3.9 to about 5.4%. So you see, we have a lot of work to do. Unfortunately, employment is not something that in years past has gotten a lot of traction. I'm so happy to be a part of this movement. We're finally starting to realize that if we're going to treat the whole person, if we really are going to have quality of life, if we really are going to thrive, we're going to have to start talking about employment. As I'm sure you all know, the Ryan White CARE Act does not allow for its funds to be used for employment. However, I'm happy to say there are some go-arounds with that, and there is a way that some funds can be used not directly for employment per se. However, the funds can be used for benefits counseling, which is an opportunity to help people understand how going back to work will affect their benefits. Unfortunately, many of the people in our community live on SSI and SSDI. Stop and think for a moment about what your salary is today, what your income is for 1 month. SSI recipients who receive SSI live off of $914 a month, right? Many of us make more than that in a week. The average SSDI disability check ranges from about $1,200 a month to $1,400 a month. Many people on Social Security disability have a fear of going back to work because they believe that if they go back to work, they're going to lose their cash benefit and they're going to lose their insurance. And we all know how important our medical coverage is for each of us as we all live with HIV. There are programs in place for individuals who want to go back to work, but really the information traditionally has been really, really hard to find. Social Security has not done a good job of making that information easily accessible. Mark Mizrak, Vanessa Johnson, myself, and now Martha are working hard to try and bring together a collection of information that will be readily available for individuals living with HIV, so you can understand how going back to work will affect your benefits. Employment is one of those things that not only deals with employment, but it also deals with housing and food security. Because once you're employed, you have a better opportunity to have better housing. Many times with employment comes employer-sponsored medical insurance. So it just helps all around. Unfortunately, though, the conversations are not being had. Martha, Mark, Vanessa, and I are in the process of creating a center for expanding opportunities for people living with HIV in the state of New York. We have, for the last 2.5 years, have been providing information to HIV service providers across the state of New York on how to effectively talk to their clients about going back to work. Many people don't believe that they can. Many people have a fear of going back to work because they've been out of work for a really, really long time. They feel like their skill sets might not be what an employer is looking for. Sometimes we forget, as long-term survivors and people living with HIV, we are subject matter experts. And those things, those tools, and all the experience we've had to live our lives effectively across our journey are good tools for employment. It's been my experience, I live in Virginia, and it's been my experience that providers locally are not willing to try to talk to their clients about going back to work. It's a little bit harsh to say, but in some instances, it's been my experience that some providers feel that, especially case managers sometimes, that if people become independent, then they're going to be out of a job one day. I coined a program at the University of Virginia, and it's called the Pathway to Independence. And I spell independence with an E instead of an I, because I want to see people in our community in their dependence on public programs and entitlements and social programs. It's really, really important that now that we're going to live, that we go ahead and not just live, but we begin to thrive. One of the ways that we thrive is that we begin to take charge of our own lives. Work is not for everyone. We understand that. But there are many of us who can work if we're given the information, the resources, the tools, and the knowledge to be able to make well-informed decisions about going back to work. It has also been my experience that many people are fearful because they have not worked for so long, they're unsure if they can go to work. People that are on Social Security disability benefits have the ability to go back to work without losing their cash payments automatically and initially. And that's a wonderful safety net program. A lot of people don't know that if you're on SSDI, you can work up to a year before your cash payments are affected. If you're on SSI, because that is a government subsidy, your benefits are affected, but they're not automatically taken away. Members of our community have to start making some noise about employment and what it means to us. Employment for me has been that thing over my 33 years of living with HIV that has allowed me to hold on to life. There's nothing like getting up in the morning and knowing that you have something to do. You have an opportunity to get out of the house, to interact with people, and to just be a part of something. For so long, we thought we were going to die, but now we can live and we can thrive. And employment is one of those things that will help us get there. We've got to begin to have more conversations about what it means to be employed and the resources and information that's out there for us to be able to be employed. Martha, Mark, and I just came back from Charlotte yesterday after an awesome all-day employment forum in Charlotte, North Carolina, where we brought together people living with HIV, service providers, and other providers such as Voc Rehab, the American Job Centers, and providers of service all over the city under one roof for the first time ever in most instances, to see how we can all work together. So it's an opportunity for all the agencies in the area to come together to see how they can best help individuals living with HIV. It's been my experience that in the Ticket to Work program, vocational rehabilitation, and in the American Job Centers, people with HIV are not seeking these services. Many times it could be that they're not aware that the services are available. It could also be that it's not being readily advertised that those services are available for us. And then there are just some individuals who just don't know. But it's really, really important that as we move forward and as we talk about the ending the HIV epidemic and treating the whole person, that we really, really, really take a look at employment and economic stability. The state of affairs in this country right now says that we cannot depend on the government to help us. We have to begin to take charge of our own lives. And part of that is our community coming together collectively, having a conversation and raising our voices that we are not going to stand for anything less than all the information, resources, and tools that we need to be able to live effectively, not only to live, but to thrive. And with that, I'll stop and ask if there are any questions.
I was just saying, wow, Sylvester, I know every time I hear you and Mark speak about this, I wonder why I had not heard about this. I'm going to ask one quick question just for you to touch on and connect, maybe in just a couple of minutes, just also speak about housing and perhaps HOPWA. And how it also connects with our employment, just so that people can have that perspective as well. And we will hold questions until the end. So after Sylvester, we'll move on to Melanie, and then we'll keep going. But thank you so much, Sylvester. If you can just touch on housing as well.
Sure. So housing is one of those things. Unstable housing is one of those things that can be partially corrected with employment. So many of us live in unstable housing, and some of us live in unstable housing. So we know about the HOPWA program, which is housing opportunities with people with AIDS. What many of us don't know, that a portion of that resource is about to go away. As of December 31st, 2023, there's something called earned income disregard, which means that a HOPWA participant, when they go back to work, that first year, their income is not counted as part of their rental calculation. Beginning with year 2, only 50% of their new income is considered in their rental calculation. And then in year 3, all of your income is then factored in. But this is a wonderful opportunity for people to have the opportunity to save some money, to become stable in their housing. And it's unfortunate that this is going to go away. We understand that there is going to be another program, but it probably won't have as much depth as the HOPWA program has. But many of us live in unstable housing, and having an employment, having stable income is a bridge to stable housing. You're on mute, Martha.
Of course. Thank you so much. I know that, folks might have quite a few questions for you. You've shared some really critical information, and I really enjoyed myself in Charlotte, just hearing from organizations like Goodwill, and, colleges that have all these programs, free assistance, and different kinds of support for people just trying to get to work, and also considering mental health as well. Mental health support. But why don't I move on to Melanie, because I think Melanie will help us expand our perspective as it relates to those of us aging, dealing with mental health, and anything else. Melanie, I'm so pleased to introduce you.
Good evening, everyone. My name is Melanie Reese. My pronouns are she, her, accomplice. I have been living with HIV for 24 years. And of those 24 years, 20 years I've been an advocate, an activist, sometimes a community organizer, and I have accepted the fact that I am aging with HIV, and with that knowledge, I have a biological age, which is 71, and I have a chronological age, which is 71, and a biological age, which is probably about 86 years old. And trying to talk to health providers about the discrepancy in those two is quite difficult. And a lot of times when you go to see a provider, that's not I have a primary care ID doc, and then I have several specialists. The specialists don't quite wrap their minds around the biological age. And they see my concerns as maybe you're putting too much emphasis on some things. Maybe it's in your head. And that's disconcerting for anyone to not be believed in the concerns that they have about the way they are feeling in their body, physically, mentally, emotionally, and spiritually, because they all work in conjunction with each other and help us to be a whole human being and operate as such. The medical community does not see us as whole persons. And that angers me because the structural systems are racist. And they don't consider people of color to be whole human beings. We just happen to kind of sort of have bodies that are similar to theirs, but we are not whole beings. And so we don't get the same medical care. We're not believed. When we go to a physician and say, I'm having pain issues, I want to control and manage them, but I don't want opioids. What can you offer me? Well, when you're on Medicare, you have very few options, okay, to manage your pain. And oftentimes when I go in and see that picture scale on 1 to 10, and they want you to circle, how are you feeling today? Well, none of those pictures and none of those numbers correspond to what I'm feeling in my body. And I was told that if you mark 9 or 10, you should be unconscious and shouldn't be able to tell me you're in pain. And that is ridiculous, because I'm feeling the pain, and who I'm trying to tell I'm feeling it, they're not believing me. And add on to that, I'm HIV positive. So there's a bias because not only am I aging, I have a disease that the general population, including medical providers, think that I did something to deserve it. And in their mindset, I should be happy to accept whatever care they want to give me. So they're not concerned about my well-being. And I know enough to be concerned about my well-being. And aging and well-being, aging impacts well-being. I live in a senior building because I cannot maneuver steps. I need bars in my bathroom, in my shower. I need the levels of the sink to be where I don't have to reach up or bend down. I have balance issues. So if I lean too far forward, I'm going to keep going. If I lean too far back, I'm going to keep going back. If I lean too far to either side, I'm going to go to that side or the other. And usually the landing place is the floor, and you can injure yourself. So living with HIV, which is a manageable chronic disease, taking medications to manage that chronic disease creates other co-occurring chronic health conditions, which some require other medications. And when you are on too many medications, there is an opportunity for drug-to-drug interactions, which can create other issues for someone who is trying to manage their well-being and their mental health. And we have to educate the general population, elected officials, our health providers, our case managers, the health department personnel, the federal agencies about who we are as whole persons. They
Right.
talk a good talk about whole person care, but they don't even know what it is. It's just a statement that they think sounds good, but they have no way of implementing it. And they have no way of holding people accountable who are supposed to be implementing it. And they don't hear. They have thousands of listening sessions, but they don't hear us.
Yeah.
The fact that they don't hear us creates massive problems to communities who are heavily impacted by HIV, heavily impacted by poverty, heavily impacted by housing insecurity, food insecurity, inability to obtain adequate transportation to do everyday things, not to mention getting to your medical care and grocery stores and, just everyday living. You need these things
Yeah.
in order to have a quality of life. Now, definition of quality of life could become individualized because each individual has an idea in their head what quality of life is, and they're not the same. So when we talk about quality of life and that a governmental agency has indicators for measurement of quality of life, and they're not talking to us, hearing us to,
To define.
yes, to define those indicators, then what's the point?
Right. No,
Because if the federal level trickles down to the state level, which trickles down to local jurisdictions, trickle down regardless if it's medical care, finances, housing, trickle down has never worked and never will work. It needs to flow upwards, which means those of us who are near the bottom or at the bottom need to be supplied what we need first, and then whatever left over needs to move up. Then things can begin to work differently.
yeah, Melanie, you've raised some really, really great points. And I think that the key to what you were saying is, how are they measuring this? How are they measuring the fact that, when I get out of bed, first I have to transform, I have to stretch my legs and stretch my arms. And how do I describe that? And how do I get the doctor to listen to me? And the doctor needs to understand that, everything that I'm feeling is at an accelerated pace because I'm a person living with HIV. And I think you raised the issue about being treated as a whole person. I've actually heard somewhere where they talked about holistic care, and this doctor that was speaking said it's holistic care, starting with a W and not an H. That is what we need in HIV, that they need to treat our minds, our souls, and our bodies, because mental health really does have a huge impact on our medication as well. So thank you so much, Melanie. I know there's been a lot of comments in the chat and people agree with you. I'm going to move on because I want to get everybody in before we start having our community discussion and questions. And I want to introduce Miss Mary. She's last of our speakers, but definitely not the least. And I would love to hear her speak about nutrition and other things that impact our health and quality of life.
Thank you, Martha. Good evening, everybody. I am so honored to be here amongst all of you, especially speaking amongst Sylvester and Melanie. It's a great honor. For me, I am kind of at the tail beginnings, I should say, of the aging with HIV. I am 49. I've been positive for 21 years. So, you know, it's individual on how you define HIV and aging, but for me, I like to view it as I'm part of the second wave that's coming. You know, we have our elders, I guess you can call them, who have been positive 30 plus, some that I've actually met 40 plus during USCHA. So, you know, when this first started, we didn't think they'd last 4 weeks, much less 4 years, right? So, yeah, so me and HIV and aging, I feel like I'm just coming into this. And so I'm looking at it with somewhat different eyes than what some folks do. Like I said, I look at it as we're learning from what's going on and what's going to happen in our discussions and in our advocacy for what's going on with our folks right now. And then how can we improve upon that for this next round of folks coming through. A little bit about me. My name is Mary Lucero Hill. I am in Denver, Colorado. I am a native of Colorado, born and raised in the southern region in a smaller community. So I'm familiar with some of the rural areas of Colorado and worked in those areas as well. I am the newest co-chair to PWN Colorado, and I am a co-chair for improving outcomes for the COHAS. For employment, I am a case manager for a smaller agency working primarily with women, individuals identifying as females, doing case management under the Part B grant, but I do work somewhat with Part A as well. Like I said, I've done case management for about 10 years now, and it's had its good and its bad moments regarding the barriers and the challenges that some of my clients have worked with, and then some of my own as well, you know, mental health wise, trying to separate out the worker Mary from the HIV positive Mary, from the friend Mary, you know, it can get a little bit overlapping. But when it comes to nutrition, so I'm going to talk about mental health and nutrition. So when it comes to nutrition, though, I want to talk a little bit about some of the food deserts that are out there for both the metro and for rural areas, as well as some of the things that Melanie and Sylvester have already touched upon with barriers to accessing these and how they kind of intersect with one another. So when it comes to nutrition, you know, it depends on the person that you're working with or that you are. The individual could be a housed person or an unhoused person. Those types of things that you're looking at are very different for each of those individuals. If they have a job or if they don't, if they are active in their care or if they're not, you know, all these factors go into what it's like to have enough food on the table and access to it as well. So with the food desert locations in the rural areas, especially here in Colorado, it makes it difficult to get any type of nutrition, really, because the food pantries, even in the bigger cities, are dwindling right now. The main things that we have at a lot of our food pantry locations are canned goods, not fresh fruits. And so we all know that a lot of the processed foods, a lot of the cans have a lot of sodium as we're aging. Even for us that aren't aging, high sodium's not good for us. And all the good stuff that's supposed to help us, like the fresh fruits, the fresh vegetables, just the fresh herbs, all that in general, there's a lack of it. And to Sylvester's point, you know, with income of any kind, even if you have a job, doesn't mean that you're going to be able to afford your housing, afford any type of copays, if you have any copays for your medications, because not everywhere has a good ADAP program. And then on top of it, to have food on your table, even if it's processed or if it's fresh, there's the money only goes so far. And so there's so much that we do the side hustles with, some of them not so legal, but some of them, some people, that's what they have to go to, you know. And I have clients that have went that route, and it's because they have families and they have to support little ones, you know. I just heard on the news that I think it's somewhere in one of the Carolinas that they're going to not feed children if they don't have the money to pay for their lunch. And this is in like middle school, grade school type of thing. Don't quote me on the logistics, but I do know that it was somewhere over in the Carolinas, one of the Carolinas, and one of the school districts. So if you don't have money to eat, you don't eat. And for kids, that's like the only meal that they have during the entire day is their lunch. So, I mean, if it's happening to kids, it's happening to us as adults, unfortunately, because they're more vulnerable than what we are, you know. along with the food droughts, we have the food stamp drop that everyone had in March earlier this year. So that makes it even more difficult for us to get any type of food that we can even stock up on, you know? Even if you were to go to like a meat market, what can you buy for $23? Because that's what some of us get, you know? Some of us, even on SSI, SSDI, that's what some of us get per month is $23 for an individual, or others may get up to 130 or some. I don't know the actual amount, but for a single person, it can be up to that as well. But what do you, even with $130, what are you gonna buy? You know, with the price of the staples like eggs and milk and ground beef, which, you know, we're not supposed to have a lot of ground beef, but it's cheaper than ground turkey and ground chicken, you know? So we're having to compromise our diets in order to have any type of sustenance at all. And it's making it harder on our bodies to process and interact with the medications that we have. I wrote notes. There was one thing. Food allergies. Yes, food allergies. That's what I wanted to talk about. A lot of us that have multiple medications for not only HIV, but for comorbidities as well. Some of the medications can interact with some of the foods that we eat. Can't eat grapefruit. Well, that's a good source of vitamins right there. So that cuts that out, right? So when we go grocery shopping, we have to be extra cautious and extra careful. We have to know more about what's how our medications interact with the foods that we're eating, kind of like what Melanie was saying, you know, you can't just eat this and be okay. So it makes it a lot harder all the way around, which taxes our mental health status, or our mental health well-being in doing so. And we all know that stress is a killer for everyone, especially those of us with HIV, because our system's already compromised, and any type of added issues rising can cause more issues in the long run. I just want to keep it real short and simple, to the point that we just, you know, it's difficult for our rural counterparts to get food and proper nutrition, but it's just as bad in the metro areas, because I see it working with the folks that I work with on a daily basis. Transportation, that's the other thing, transportation. To get these types of foods is even harder.
And in some cases, there's some areas, you know, where people live where you won't even find grocery stores, again, because
Exactly.
of thematic you know, issues that happen with our communities. But also, I mean, in the past 2 years, as prices have gone higher and higher, it's just been hard for people to get food. But you've raised some really excellent points, Mary, including like the interactions with food that we need to be conscious of, and that the resulting stress in us not having access to some of these things only goes to impact even our health, our weight, and so on and so forth. So there's so much going on, and you have raised some really good points in terms of our nutrition and the support that we need. Even, you know, when you talked about the fact that even as we were to start working and we are trying to build our capacity to be independent, as Sylvester was saying, one of the things to consider if you are getting SSDI or SSI and you're getting food stamps, sometimes as you try to enter the employment realm, is the fact that you may end up losing some of these other benefits. And so you have to balance all of that and get all the information that you need. And I've seen some amazing information that is given out at some of the workshops that Sylvester and Mark train at. But I just want to thank all the panelists. I mean, you all have shared some really great info that is real, that these are our lives that we're talking about. And this is what quality of life means. And as Melanie was saying, we have listening sessions, but are they listening? You know, are they listening? So we have quite a lot of comments in the chat. And I'll go ahead and take questions. I think Israel made a couple of comments, and one of the comments that you made really touched me about having insurance. Do you want to come off mute and just share that, Israel? Okay, maybe
Disculpa lo que consigo el micrófono. Ya no sé ni lo que escribí, pero pues saludo a todos primeramente. Tengo la experiencia de un compañero, un activista muy reconocido en Puerto Rico, que estuvo trabajando, dejó, ¿verdad?, el seguro social porque le ofrecieron nuevamente trabajo. Estuvo trabajando por un tiempo y luego lo sacaron del trabajo. Trató de conseguir en otros lugares, no le han dado el espacio, así que fue con un abogado para solicitar nuevamente el seguro social y se lo denegaron. Otro de los casos bien importante pues es el mío particular. Yo tengo las 3 licencias que otorga el Comisionado de Seguros de Puerto Rico. Trabajé por 13 años para una compañía de seguros médicos muy reconocida en Puerto Rico. Y cuando comencé con el HIV, ya yo tenía una condición que agravó un poco la situación, pues a los 25 años me dio cáncer. So, cuando me da el HIV, no de inmediato, pero comienzan las comorbilidades y pedí en mi trabajo un acomodo razonable, explicándole. Y me dijeron pues que no había acomodo razonable, que yo había llenado para un puesto y para eso fue que se me contrató. Que como único me podían dejar regresar al trabajo nuevamente era que los médicos certificaran que a mí no me iba a volver a dar convulsiones, que a mí no me iban a volver a dar quimioterapia. So, estuve 8 años buscando empleo mientras solicitaba a la vez el seguro social. Nunca en ningún lado me dieron el espacio para volver a trabajar. Después de 8 años de estar con 2 abogados para solicitar el Social Security por incapacidad, me lo dan y me quitan el retroactivo. Pierdo todo el retroactivo, o sea, simplemente me dieron el seguro social y todo lo que yo tenía para el retiro de mi vida, yo cobraba muy bien, Yo viví esos 8 años con ese dinero que yo tenía para mi retiro. O sea que yo ahora mismo estoy viviendo solamente con lo que me da el Seguro Social. Y aquí en Puerto Rico, sé que no es en Puerto Rico nada más, pero hablo de mi país. Está bien difícil la situación. Vivir con el Seguro Social no da. Aquí nos han subido el agua, nos han subido la luz, el pago de la casa, teléfono, misceláneo, compra. Esto es una locura total.
Yes.
Y el Seguro Social ha enviado cartas como que para que regrese a trabajar, pero es que no le dan la oportunidad a uno. No le dan la oportunidad a uno. Yo estuve buscando trabajo y no le dan la oportunidad. Entonces, el miedo de todo es llegar a conseguir algún lugar que me dé la oportunidad de trabajar y que me pase como esta activista que no menciono su nombre porque pues no fui autorizado a contar su, ¿verdad? Su historia, así que la cuento anónimamente. Y el miedo mío es quedarme sin mi techo seguro, porque viví 8 años con el temor de perder mi casa por lo que yo luché por tanto, o sea, el sacrificio de tantos años de trabajo. Eh, es bien difícil,
It's
es bien
tough.
difícil.
Yeah, yeah. Well, Israel, I mean, thank you for sharing. I was gonna ask maybe Sylvester to just respond to some of the things that we heard, but I know that Puerto Rico is, I mean, if we face challenges in the US, I know Puerto Rico just has double doses of it because of the, challenges that it has faced. So, Sylvester, did you want to respond?
So I didn't hear all of the first part of the conversation, but I will respond to what he said about the letters that he was getting from Social Security about going back to work. Social Security cannot force you to go back to work as long as you continue to meet the Social Security definition of disability. Most people on Social Security disability are on a 3, 5, or 7-year review cycle. Sometimes they happen with you knowing, sometimes they happen without you knowing. But what they do is they check your medical records to see that you continue to be disabled. I don't know what kind of legal advocacy agencies you guys might have in Puerto Rico, but I would encourage you to look for something like legal aid or disability rights and resources. Also, I would encourage you, there are what's called WIPA programs, work incentive and planning assistance. You can go on to choosework.gov, put in your zip code, and you will be able to find a WIPA program in your area, and they might be able to point you in the direction of some resources that will help you in your situation.
Yes, thank you, Sylvester. So I was actually a little bit surprised that they would force him.
Gracias. Quisiera decir otras palabras, pero como sé que tienen que cambiar para lo de inglés, pues, José, me dices cuando estén listos. Ok, pues una de las cosas bien importantes también es que en las clínicas de inmunología, ellos te indican que, o sea, yo te atiendo para el HIV. Y yo estoy totalmente de acuerdo, pero tú tienes que entender pues que yo no soy un atípico paciente porque tengo múltiples condiciones con múltiples comorbilidades. Así que a mí me crearon por no estar pendiente a los medicamentos. Tomo más de 30 medicamentos sin contar 2 diferentes quimioterapias que me tienen que dar. Y me causaron lipodistrofia al extremo de que me aplastó la próstata, los intestinos, y tuve que ir a cirugía que no costeó el plan médico. tuve que hacer por medio de donativos. Y ahora tienen que volver a operarme porque no pudieron sacar la lipodistrofia interna, solo la externa. Y esto todo fue provocado por no estar pendiente a esos medicamentos que reaccionaban con el retroviral y la quimioterapia. O sea, esto es algo, ¿verdad? Un poco serio, algo por lo que yo estoy
Yes.
abogando y
Yeah.
nada, quería dejárselo saber.
Right. Yeah. Barb just said in the chat that we really should not, and this is what I was talking about in terms of human rights care. We should not have to go to GoFundMe, to raise money for care. Healthcare is a human right. And in other places, they have universal care, and you shouldn't have to beg to be taken care of, especially when you have such difficult conditions. But I think what Israel is saying, and I think this is what was reflected among all our participants, is that we are going to have comorbidities and other issues impacting us because of our HIV, because of the inflammation, or even when other regular things impact us, they're going to be exaggerated because of our condition, because we can't access nutrition, and because we don't have a holistic approach to our healthcare. So my heart goes out to you, Israel, but I really do believe, did somebody want to say something that, they are services, I think, and this is what NWPC does, is sometimes we miss out because we don't know some of the services that are there that help people with disabilities, that help people with care. And I think it would be good for us to collect some resources that we can share, especially after this webinar.
Martha, it's Sylvester. Just one quick thing I wanted to say about Puerto Rico. We found out when we were there last year that individuals can get SSDI, but individuals living in Puerto Rico are not eligible for SSI.
Right.
That is really, really crazy. So Americans, and even if you move to Puerto Rico and you're drawing SSI in the continental United States, you're no longer eligible for it if you move to Puerto Rico.
That is just, I was going to use maybe some not usable language.
Yes.
But yeah, I would love to, just as we have done in some of the other places, begin to sort of collect resources, especially as they relate to the things that we're talking about, so that people can know where to get, in case they get letters from SSI, in case they're being harassed, in case they're being denied benefits and so on, that we can have a place where we can have resources for them. Jacqueline in the chat spoke about also having to take care of parents, and that is something that we just don't consider, that we're also caregivers and we're taking care of other people. Jacqueline, did you want to come off mute briefly and just share? I don't know if they're still here.
Hello everyone. Hola.
Yeah, go ahead.
Lo que compartí en la caja de charla fue que aquí el seguro social casi no nos da. En mi caso, mis papás son quien cubren los gastos que yo no cubro. Y yo tengo que cuidarlos a ellos. Y tengo otras enfermedades que a veces me impiden hasta levantarme de la cama.
Wow. And are these medical costs?
En gastos médicos, el plan a veces cubre. Pero el problema es que en mi caso yo vivo solamente, o sea, mi ingreso es el seguro social, $868. Pero mis gastos son casi 1,000 o más. mis padres son los que terminan pagando lo que yo no puedo cubrir. Y así hay muchas personas que reciben menos que yo, que no tienen cómo cubrir otros gastos. Hay personas que dejan de comprar medicamentos porque no tienen cómo pagarlos.
You need to help.
Y en base a lo que estás hablando, que Puerto Rico es parte de Estados Unidos, pero en muchos de los casos, muchas de las cosas que hay allá no llegan acá, como el exercise, que no es parte, no lo dan.
Right, right. And this is a real issue about us having elder care, child care, even pet care for some folks. And we know that you know, Social Security is not enough. Maybe they're not getting Social Security. Mary, did you want to speak a little bit to that? I know that you were a big part of creating your sort of national local HIV strategy, and if it had anything to do with aging. Is there anything you would be able to respond to, Jacqueline?
I honestly don't. So, okay, the question was, say it one more time. I was in and out.
You're fine. You know, Jacqueline was talking about how on top of her own disability and having to take care of herself, she also has to supplement her parents.
Mhm.
And a lot of people have to do that, supplementing parents, supplementing other elder care, supplementing family, and just generally, you know, having the extra burden of taking care of other people on the limited income that might be, especially if it's SSI and so on. So I just wanted to see if you had anything to say to that. And Melanie as well, our panelists.
You know, that's what makes it a lot harder, honestly, to take care of ourselves, is we utilize some of the money that we have coming in for ourselves to make sure that our loved ones, in this case, her parents, are taken care of, because the system is failing all of us around. I think I'm going to keep it right there before I start to get on a high horse and start blaming people I shouldn't need to be blaming.
Well, we all know, you know, that we're generally thinking about our government and how it treats our people. And so we need to be thinking about our voting as well. But I'll give Melanie just a couple minutes to respond generally. And then I really think that hopefully one day we can have an extended session on SSI and work. And I think this all goes back down to, you know, what we were saying. And I know work is not for everyone, but, you know, to just be thinking about ways in which, you know, people can, A, understand the systems that are there and how to maximize them or get legal help with them, but B, for those that are able, can have creative ways to become independent of some of these programs. But Melanie, I'll give you a couple minutes to respond, and then I know Wanda raised her hand, and I wanted to hear from her too. I know she had something to share, so I'll just give you a few minutes, Wanda, to just reflect. Go ahead, Melanie.
I wanted to say that like the end the HIV epidemic, the individual integrated state plans do not really address aging and aging with HIV in their plans. And Baltimore's EHE plan did, because I was on the EHE plan committee, and I insisted that they put aging and aging and HIV in our plan, and that was not in the majority of jurisdictional plans across the nation. It's ageism is another thing that we as people living with HIV have to deal with. Ageism is a serious issue that people who are aging are neglected. They are discounted. They are pushed aside. And it's really sad because we should be honoring our elders and not putting them to the wayside to fend for themselves the best way they know how. And those of us who aren't able to work in some way, shape, or form, we're going to have to find other ways to supplement, because we cannot live on what the government programs allow us. And we have to fight to disrupt and dismantle eligibility requirements for people who are living with chronic diseases, including HIV,
Yes.
because we are putting their health and lives at risk if we don't remove them.
Yeah, it's very, it's you know, it's just so sometimes I feel disrespectful that they want every piece of information about you. You have to produce everything, you know, including eye color and DNA samples just to be eligible for SSI. But yeah, so Ms. Wanda, I'll give you just we're going towards time, so I'll give you about a couple minutes to just share. And then we can kind of wrap up with, you know, some of the things we can think about advocating for, you know, based on the discussion, and where you can take your advocacy, and where you might be able to find resources. Go ahead, Ms. Wanda.
Thank you, Martha. First, I want to, Jose, am I speaking properly? Can you follow me? Oh, okay, love you. First, I wanted to address the conversation around Puerto Rico. I was educated very thoroughly, and unfortunately, you know, scrambled eggs. I don't remember everything that was told when I went off on a rant for hurricane benefits and stuff like that. What I was informed of at that time was that when Puerto Rico became a territory of the United States under whatever president set it up, and I do not recall, it was a long time ago, but they essentially screwed the Puerto Rican people from having benefits like we take for granted here on the continent of the North America, the United States, our states. So that is a huge problem, and I do not know if it can be readdressed, refocused, or whatever, so that my brothers and sisters that are living in Puerto Rico can get their rights.
Right.
So speaking of rights, hey Carrie, glad you're here. And I just want to tantalize a little bit right now what is going on with me. I am currently in the hospital. Have been here since Saturday. After was not well. I knew I was pushing going to USCHA and positive living, but was determined because many of the things that Mary spoke of, Melanie spoke of, Sylvester spoke of, the isolation and the starvation and the housing insecurity and not feeling safe and not, I ticked all the boxes. And this being sick is going to afford me an opportunity to test my waters for the benefits that may be available to get me into stable, safe housing. As I know, Melanie, I love you. I am using it for my Batwoman strengths to seek out and be unafraid and unembarrassed to ask for what is rightfully mine as a woman of 69 years of age, chronologically, probably, as Melanie said, more in the order of in my 80s, thanks to 21 years of living with this virus. So I will just leave it at that. Say, stay tuned. I will be sharing. It's a roller coaster ride so far, and it ain't done yet. I will be tested for RSV. I did learn that because of contracting COVID, I cannot get my next booster for 90 days. That
Right.
was a piece of trivia that I was unaware of. So
Yeah.
as I learn, ye too shall learn. And
Yes.
I love your support. And I will be putting more out either via Facebook or working with a magazine friend.
Wow. Well, thank you, Miss Wanda, and we're wishing you just healing and loving vibes. You know, we love you, and we know, you know, your advocacy, your persistence in advocating. But you know what I find so painful is that literally this is what they want. You know, they want you to literally be incapacitated like this before you know they can listen and before there's action. Even in the early days of
This is
HIV.
not incapacitated. We are
Yes,
rising up.
right.
If I can't stand on my own, somebody holds me up.
Yes, yeah. And you are an inspiration, because even in the old days of HIV, people could not get disability until they were literally on their deathbed. So what we have heard, and I'm gonna pull Barb in here, you know, to help us round this up is, and I think it was Melanie that said, education. I think we need to arm ourselves with the information, such as the information that Sylvester shared. We need to advocate for the things that Melanie talked about. She got aging into her EHE plan because she spoke up. So we need to be active in our planning councils, our EHE spaces, so that we can uplift these issues that have been raised. This is the real listening session that is there. This is what our people who are writing that national HIV/AIDS strategy and trying to keep people accountable, this is what they need to be accounting for. And I really hope and pray that we can get to have a listening session, like we can move this conversation in front of our advocacy, and we can only do that with you. So the things that you have shared, the things that Israel has shared, the things that Jacqueline has shared, I mean, what Wanda is going through today, this is quality of life. This is what we mean. This is what we're talking about. And we have to, for those of us, Ms. Wanda, I know you speak, even if they put a oxygen mask in you like now, but we need to speak. We need to continue speaking and being inspired to speak about quality of life. Barb, why don't I let you bring us in?
Yeah, thank you, Martha, and thank you everyone for joining us with this, amazing quality of life conversation. This is actually just the first part of this conversation. On Friday of this week, we're going to actually follow up with a companion community conversation. It will be about advocacy around quality of life. And so we'll talk about how we've managed to include some of the metrics that have been listed in these 5 metrics that the federal government is following, but also ones that we know are important that haven't been listed. And so that'll be quality of life advocacy. It'll be Friday. It will be at, I'm not even going to say the time. We had to switch the time, so I'm not even going to say it.
Okay.
But we'll go ahead and make sure that everybody receives the invitation to it. Because here's what's so important and what we need to remember is that we deserve quality of life. We deserve to be treated well, to be comfortable in the spaces that we live, to have sufficient nutritional food that we enjoy. We deserve to define quality of life however we want to define it. For one of my friends, quality of life to them means that they have enough money left over at the end of the week to be able to go and see a movie and pay for a bucket of popcorn. And so for them, that is what quality of life means. We do not need anyone else to define what quality of life means or how it shows up in our lives. This is, again, comes back to why we must be meaningfully involved in any program or policy that impacts our lives. We save the money, actually, because if you implement a plan that does not have involvement with people living with HIV, chances are it's probably not going to be as successful as it could be if we were there from the beginning to talk about what is important and what we know within our community, and especially what we know from those that are most impacted, that those who are closest to the problem are also best able to identify what the solution is. So I just want to go ahead and, as we're coming to a close, thank Martha for facilitating, thank Melanie, Mary, and Sylvester for sharing their thoughts as panelists, for everyone who has been on, for Omni, for their incredible language justice and making sure that we are able to involve our community in every aspect in how they show up. And so thank you for your interpretation and always your beautiful, beautiful presence. You know, this has been a community conversation that has been led, developed, and created by people living with HIV, with no one else coming in to tell us how we need to show up, how we need to talk to each other, and how we need to elevate what we know is most important in our lives. Community has always and will always lift us up and lead us in ways that are not at all mistaken, that are the power in our community. And one of the things that we did have was from the early days of the HIV epidemic. Somebody said, you know, in the early days, we didn't have the medication, and we know now that the medication is only a part about how we are here and how we live, and sometimes are able to thrive, and some days just barely scrape by. When we're scraping by, I just want to share that this is not due to any lack of strength of character or engagement from ourselves. It is that the system has failed us. And as Melanie said, we know that the system is racist. As we talk about what happens in Puerto Rico, we know that systems have been developed to keep them as a territory, to keep them as a colony, and that is not acceptable. So when we advocate for our needs, we advocate for what our community needs. And we fight back against that racism, against that colonization, and against the gender bias, because I just want to remind people that the AIDS defining illnesses that qualified people for support did not include anything that involved women until 1993. And that was advocacy by our community. So hopefully everyone will be able to join us on Friday as we continue to have this conversation. With that, I want to thank Martha once again for an amazing job facilitating, Omni for an incredible job interpreting, making sure that people had access, and for everyone who's joined us and has shared their questions, comments, and thoughts in the chat. And with that, we're going to go ahead and just stop here for today, knowing that this is a conversation that continues in every way, every space, and every place that we show up. So with that, I will thank you all for joining us today.
Have a good night.